A tiny scratch on your knuckle from, maybe a late-night bar fight.
Right, something that seems completely trivial.
Exactly. I mean, you wash it out, you put a bandage on it, and you go to sleep. But then, within 48 hours, the cartilage in your joint has completely dissolved.
It's terrifying.
It really is. Or consider a perfectly healthy-looking thumb. No cuts, like no trauma at all. But quietly and painlessly, it's just dying from the inside out.
Yeah, that's the thing. Today, we are looking at these medical emergencies that, well, they present with a whisper, but they end in amputation.
Which is just the ultimate diagnostic paradox.
Right.
I mean, usually in orthopedics, the severity of the injury, it matches the presentation.
Oh, absolutely. A commended femur fracture looks like a catastrophic emergency. You can't miss it.
Right, it's obvious. But in the hand, the most devastating pathologies, they sort of, they hide their severity.
They really do. You're racing against a biological clock, and, the early signs are incredibly subtle. By the time the hand actually looks like a massive emergency to an untrained eye, well, you've already lost the battle. I mean, the tissue is dead.
Which brings us to the core philosophy for our discussion today. The single mantra you need to internalize right from the jump is this: look small, act fast.
Look small, act fast.
Exactly. Because today, we're conquering the hand. Specifically, we're diving deep into the infection and vascular modules. And we know exactly who's listening to this right now.
Well, we do.
You're likely a surgeon. You're deep in the trenches prepping for your trauma and orthopedics fellowship exams. The DNB Orth, the MRCS, or the EBOT.
And we also know that because you are a busy clinician, you aren't like sitting at a desk with a highlighter.
Definitely not.
You're probably driving home from a horrific night shift, or you're at the gym or doing the dishes. Taking notes is just completely out of the question.
Yeah, absolutely. So we are going to treat this as an intensive, audio-only survival guide. We've actually built the required repetition directly into our conversation.
Right, so you don't have to rewind.
Exactly. Because you can't write this down. Every single list, every critical number, and every high-yield exam discriminator is going to be stated twice.
Twice?
Not in a robotic way, but we'll make sure we loop back and lock it in. We'll do 2 mid-episode recaps to consolidate the knowledge, too.
And if you only have room in your brain for one takeaway per topic, we'll give you that definitive summary line.
Yeah, that if you only remember one thing line. And we'll finish up with a rapid-fire lightning round.
It's all about giving you the exact pattern recognition you need for the exam while, explaining the fundamental why behind the pathology.
Right, so it actually sticks in your long-term memory. Okay, let's unpack this. We have 2 families of emergencies today: the infected hand and the ischemic hand.
Starting with infection.
Yes, starting with infection and the microscopic invaders that cause it. Let's talk about bite organisms.
Oh, this is a classic exam topic.
It really is. So if a candidate is staring down a multiple-choice question about a hand infection and they absolutely blank, what is the statistical king of the hill?
If you're guessing blindly, the supreme ruler of hand infections, and this includes most bite wounds, by the way, is Staphylococcus aureus.
Staph aureus?
Yeah. It is the overall most common organism. I mean, Staph aureus naturally colonizes the skin of a significant portion of the population anyway.
Right.
So anytime the protective barrier of the skin is breached, whether it's a bite, a puncture from a rose thorn, or even a surgical incision, Staph aureus is the first in line to invade the underlying tissues.
It's just waiting there.
Exactly. It's highly pathogenic. It produces tissue-destroying enzymes, and crucially, it thrives in the closed spaces of the hand.
Okay, let me make sure I have that locked in as our baseline, stating it twice for everyone listening. Overall, most common organism in hand infections, including bites, is Staphylococcus aureus.
Bodar.
Overall, most common is Staphylococcus aureus. But the examiners aren't just going to test the baseline, are they?
No, they love the exceptions.
Right. They want the specific flora associated with different types of bites. So let's start with the human mouth.
Well, the human bite is notoriously filthy. When you see a human bite, the specific organism you must immediately look for on the exam is Eikenella corrodens.
Eikenella corrodens?
Yes. This is a fastidious gram-negative anaerobe. It's part of the HACE group of organisms, and it naturally lives as a commensal bacteria in the human mouth.
So in the mouth, it's fine.
Right, in the mouth, it doesn't cause a problem. But when a human tooth drives Eikenella deep into the sterile environment of a joint capsule or a tendon sheath, it wreaks absolute havoc.
Oh, wow.
Yeah, it's indolent. It often doesn't respond to first-line empiric antibiotics like flucloxacillin, and it just slowly destroys the cartilage.
So if I'm building my mental flashcards while I drive, human bites equal Eikenella corrodens.
Perfect.
repeating that to cement it. Human bites are associated with the gram-negative anaerobe Eikenella corrodens. Now, what about the veterinary side of the emergency department? Patients coming in with bites from their pets, cats and dogs?
For cat and dog bites, the primary organism to know is Pasteurella.
Pasteurella.
Yeah, it's a zoonotic pathogen, and the exams will sometimes actually distinguish between the two specific species.
Oh, they get that granular.
They do. For cats, it is Pasteurella multicida. For dogs, it is Pasteurella canis.
Got it.
And cat bites are particularly dangerous because a cat's teeth are like hypodermic needles.
Oh, yeah, they're so sharp.
Exactly. A dog bite tends to be a crush and tear injury, which, looks terrible but is often open and easy to clean. A cat bite is this tiny, deep puncture wound that seals over almost instantly.
Oh, that makes sense.
Yeah, so it basically injects Pasteurella multicida deep into the flexor tendon sheaths or the periosteum of the bone.
That distinction makes perfect sense anatomically. The mechanism of the bite dictates the depth of the infection. Let me repeat the pet bugs, just to be absolutely sure.
Go for it.
Cat and dog bites are Pasteurella. Specifically, cat is Pasteurella multicida, and dog is Pasteurella canis. Again, cat is Pasteurella multicida, dog is Pasteurella canis. So, wrapping the microscopic picture together, Staph aureus is the most common overall, Eikenella corrodens for human bites, Pasteurella for cat and dog bites.
Let me echo that core triad one more time for the listener, just to lock it in. Staph aureus is overall most common, Eikenella corrodens for human bites, Pasteurella for cat and dog bites.
Brilliant. Now let's take that microscopic knowledge of Eikenella and apply it to the physical trauma where we most commonly see it, the clenched fist injury.
Yes, the infamous fight bite.
Right. The classic presentation in an exam stem is a young male with a tiny, maybe 3-millimeter laceration over the dorsum, the back of the third or fourth metacarpophalangeal joint, the MCP knuckle.
The history is usually that they punched someone in the mouth and struck a tooth.
Yeah. But I want to challenge the surgical mandate here. I mean, it's a tiny cut. Why does a 3-millimeter scratch on a knuckle necessitate a radical trip to the operating theater?
Well, that is the exact trap the examiners are setting for you. You look at the skin, you see a tiny cut, and you think superficial. But you have to visualize the hidden anatomy.
Right. You have to think about the mechanics of the hand when the injury actually occurred.
Let me try to build a mental model here for everyone listening. The extensor mechanism over the knuckle isn't static. It moves. I like to think of it as a sliding trap door.
That's a great analogy.
Thanks. So when your hand is open and your fingers are straight, the skin, the tendon, and the joint capsule are all perfectly aligned. But when you clench your fist to throw a punch, that extensor tendon is pulled distally, sliding down over the crest of the knuckle.
Exactly.
So the punch lands, the opponent's tooth penetrates the skin, slices through that tightly stretched extensor tendon, and pierces directly into the MCP joint capsule, depositing the Eikenella corrodens.
Exactly. And what happens next is the critical moment.
Right. The fight ends, the patient relaxes their hand, they open their fist. And when they extend their fingers, that sliding trapdoor of the extensor tendon pulls back proximally to its resting position.
The holes no longer align. The contaminated tract is completely sheared off and sealed. It perfectly, hermetically locks the bacteria deep underneath the tendon and inside the synovial joint space.
That is a phenomenal visualization. The bacteria are now trapped in a dark, enclosed, avascular synovial environment.
It's like a bunker.
It is. Synovial fluid is basically high-octane bacterial food. It's a perfect incubator. And here is the ultimate clinical trap that translates directly into the exam. The patient will lie to you.
They always lie.
They do. They will present to the emergency department and say, oh, I cut my knuckle on a rusty nail, or I slipped and hit it on a piece of glass.
Because they don't want the police involved.
Exactly. They don't want to admit to the police or the medical staff that they were in a street fight. So you have to maintain a massive index of suspicion. A laceration over the MCP joint is a fight bite until proven otherwise.
So we have a highly suspicious wound over the third or fourth MCP joint. What is the actual textbook treatment? Because the junior doctor on shift, taking the patient's story at face value, might just stitch up that 3-millimeter cut, hand them a prescription for oral antibiotics, and send them home.
If you do that, you have condemned that patient to a destroyed joint and a likely amputation of the ray.
Wow.
Never, ever suture a fight bite. You never close it in the emergency department.
So what's the standard of care?
The absolute standard of care is the operating theater. You must perform a formal surgical exploration and debridement. You extend the incision, visually inspect the extensor tendon, and explore the MCP joint.
You actually have to wash it out.
You must thoroughly wash out the joint space to remove the inoculum. Crucially, you leave the wound completely open to allow for continued drainage. You heal it by secondary intention.
No stitches at all.
None. Alongside the surgery, you start them on broad-spectrum IV antibiotics covering both aerobes and anaerobes, remembering the Iconella, of course, and you absolutely must get formal x-rays.
Wait, why the x-rays? Are we just looking for an underlying boxer's fracture of the metacarpal?
That's part of it, yes, but you are primarily looking for embedded tooth fragments.
Oh, tooth fragments.
Yeah. Human enamel can shear off on the metacarpal head. If you leave a piece of a tooth inside that joint, no amount of antibiotics will cure the infection. It will act as a nidus.
Okay, let's drill this treatment protocol, stating it twice for the listener. Fight-bite treatment. Theater for surgical exploration and debridement of the wound and MCP joint. Leave the wound open. 5E antibiotics for aerobes and anaerobes. X-rays to check for fractures or tooth fragments.
And again for the back of the room.
Yes, repeating that sequence. Treatment is theater. Surgical exploration, debridement, and washout of the MCP joint. Leave the wound entirely open. Give IV antibiotics covering aerobes and anaerobes. Get X-rays for fractures or embedded tooth fragments.
The exam wants to see that you respect the hidden kinematics of the injury. Fight-bite equals theater, and the wound stays open.
Which gives us our wrap-up for this initial concept. If I am distilling this topic down for my drive to the hospital, if you only remember one thing, remember that Staph aureus is overall most common. Iconella is for human bites, Pastorella for cat and dog bites, and a fight bite over the MCP joint mandates a trip to theater for exploration and joint washout, leaving the wound strictly open.
Perfectly summarized.
Now, we just discussed an infection perfectly trapped inside a joint space by a sliding tendon. Let's move to a different kind of closed space infection. Let's talk about the spaces inside the fingertips.
A very different kind of space.
Exactly. The outline specifically highlights the Felon as a critical differential diagnosis to understand before we move deeper into the hand.
The Felon is a brilliant example of how the hand's specialized microanatomy becomes its own worst enemy. A Felon is a deep infection of the apical pulp space of the fingertip.
The fleshy pad on the palmar side of your fingertip, right?
Exactly, the fleshy pad.
So it's just a localized abscess in the fat pad. Why does that get its own special name and exam category? Abscesses happen everywhere.
Because the fingertip is not just a blob of fat. It is a highly engineered sensory organ to give us the stability required to pinch and grasp objects. The skin of the fingertip is tethered tightly to the distal phalanx bone beneath it.
Tethered how?
By dozens of dense, unyielding vertical bands of tissue called fibrous septa. These septa divide the fingertip pulp into 15 to 20 tiny, separate, closed compartments.
Oh, like the individual cells of a honeycomb.
Exactly, like a honeycomb. So when a patient gets a penetrating injury, like a wood splinter or a blood glucose lancet, it introduces our old friend Staph aureus into one of those tiny honeycomb compartments.
Like it's trapped.
Right. As the bacteria multiply and create pus, the pressure rises. But because of those dense fibrous septa, the tissue cannot expand outward.
So it's basically a microcompartment syndrome of the fingertip.
That is precisely what it is. It is a localized compartment syndrome. The pressure rises so high that it collapses the microvascular blood supply to the pulp.
That sounds incredibly painful.
It is. The patient experiences intense, throbbing pain that keeps them awake at night. The fingertip becomes incredibly tense, red and swollen. And if left untreated, the pressure will cause ischemic necrosis of the fat pad, or the infection will track directly downward into the distal phalanx and cause osteomyelitis bone infection.
Wow. So how do we decompress a honeycomb? I mean, if it's divided into 15 compartments, you can't just poke a single hole in it.
Exactly, and that's the surgical principle tested on the exams. You have to divide the septa. The traditional approach is a longitudinal incision directly over the area of maximum fluctuance, going deep enough to purposefully cut through those fibrous septa.
So you're breaking down the walls.
Yes. You open all the tiny compartments into one single cavity so the pus can drain out. Some surgeons prefer a midlateral incision along the side of the finger to avoid a scar on the tactile surface, but the goal is exactly the same: break down the walls of the honeycomb.
And what's the major exam trap here? Because the fingertip seems like a prime location for misdiagnosis.
Oh, it is. The examiners will almost always put a herpetic whitlow in the multiple choice options for a fingertip infection.
Herpetic whitlow.
Yes, a herpetic whitlow is a viral infection usually caused by herpes simplex virus 1 or 2. It presents with pain, swelling, and little vesicles blisters on the fingertip.
I see.
It is very common in dental hygienists or healthcare workers who are exposed to oral secretions.
And the distinction matters because the treatment is completely different.
It is the difference between passing and failing the exam. If a patient has a herpetic whitlow, the treatment is conservative. You give them a viral medication like oral aciclovir, keep it clean, and let it run its course.
This is no surgery.
You absolutely do not incise a herpetic whitlow. If you take a scalpel to a herpetic whitlow thinking it's a felon, you will spread the virus, risk a devastating secondary bacterial infection, and potentially cause a permanent sensory deficit.
Okay, let's lock this differential down, stating it twice. A felon is a bacterial infection of the closed pulp spaces divided by fibrous septa. Treat with surgical incision to break the septa. A herpetic whitlow is a viral blister infection. Treat with aciclovir and never incise.
Excellent.
Repeating for the listener. Felon equals bacterial pulp space infection, requires surgical incision of the septa. Herpetic whitlow equals viral herpes infection. Treat with aciclovir, never incise.
The key is distinguishing between bacterial pus under high pressure and viral fluid in superficial blisters.
Which brings us to our summary line for this specific pathology. If you only remember one thing about fingertip infections, a felon is a tense compartment syndrome of the septated pulp space requiring surgical division, and it must be clinically distinguished from a herpetic whitlow, which is strictly managed medically with antivirals.
Excellent. Now, we've dealt with the joint space in the fight bite and the pulp space in the felon, but there's a much longer, much more dangerous closed space running through the hand.
The flexor tendon sheath. This is where we escalate the stakes. Let's talk about pyogenic flexor tenosynovitis and Kanavel signs.
This is huge. Pyogenic or suppurative flexor tenosynovitis is a bacterial infection located strictly inside the flexor tendon sheath.
Okay.
To understand why this is a surgical emergency, you have to understand the anatomy. The flexor tendons that bend your fingers don't just slide through raw tissue. They are encased in a specialized double-layered synovial tube.
Similar to the pleura around the lungs, right, like a visceral layer directly on the tendon and a parietal layer forming the outer wall, with a tiny bit of lubricating synovial fluid in between.
Perfect analogy. And just like the joint space, that synovial fluid is incredible bacteria food. Furthermore, the flexor tendons have a very precarious blood supply.
How so?
They receive nutrition partly from diffusion of that synovial fluid and partly through tiny, delicate blood vessels called vincula that bridge the gap from the bone to the tendon.
Okay, so when a penetrating wound like a thorn or a needle introduces Staph aureus into that enclosed double-layered tube, the bacteria multiply rapidly.
Exactly. And the pus creates massive hydrostatic pressure inside the non-expandable sheath.
Which crushes the blood supply.
Exactly. This pressure collapses those tiny vincula blood vessels. The tendon is instantly starved of blood, bathed in destructive bacterial enzymes, and it will rapidly undergo a vascular necrosis. It will literally melt.
A dead flexor tendon means a permanently useless, stiff finger. The stakes are immense. And the way we identify this ticking time bomb clinically is by looking for Kanavel's 4 cardinal signs.
Yes.
This is high-yield, pure gold for the fellowship exams. Let's list the 4 signs first, and then I want to unpack the anatomy behind why each one happens.
Sounds good.
Kanavel's 4 signs. Number 1, a flexed resting posture of the finger. Number 2, cusiform, symmetrical swelling of the entire digit. Number 3, tenderness along the entire course of the flexor tendon sheath. Number 4, excruciating pain on passive extension of the finger.
I am going to state those 4 signs a second time because you will absolutely see them on your exam.
Go for it.
Kanavel's 4 signs. 1, flexed resting posture of the finger. 2, fusiform, symmetrical swelling, often called a sausage digit. 3, tenderness along the anatomical course of the flexor tendon sheath. 4, excruciating pain on passive extension.
Okay, let's break down the why for the listener because understanding the mechanism makes memorization effortless. Why does the finger naturally assume a flexed resting posture?
It is basic physics. The flexor sheath is a closed cylinder. When it fills with pressurized pus, the body instinctively seeks the position of maximum volume to relieve that pressure.
Right.
When the finger is fully extended, the sheath is pulled tight, and its internal volume is at its lowest. When the finger is slightly flexed, The sheath relaxes and the internal volume is maximized.
Oh, that's fascinating.
Yeah, the patient holds it flexed because that position literally creates a fraction of a millimeter more room for the pus, taking a tiny bit of tension off the walls.
Brilliant. Now, sign number 2, fusiform, symmetrical swelling. Why doesn't it just look like a localized lump where the puncture wound happened?
Because the infection isn't in the subcutaneous tissue, it is entirely contained within the sheath.
Okay.
The sheath runs longitudinally down the entire finger, and it is surrounded by tough skin ligaments, Cleland's and Grayson's ligaments, that prevent the finger from swelling out sideways like a balloon.
So it's restricted.
Exactly. Instead, the fluid tracks evenly up and down the rigid tube, making the entire finger swell uniformly, thicker in the middle and tapering at the ends. A classic sausage digit.
Sign number 3, tenderness along the flexor tendon sheath. Imagine this is just mapping the anatomy. You press on the palmar surface of the finger, directly over the flexor tendon, from the distal crease all the way down into the palm, and it hurts everywhere you press.
Exactly. Because the pus has filled the entire tube, the inflammation is uniformly distributed along the exact anatomical path of the tendon sheath.
So it's a systemic tube issue, not localized.
Right. If the pain is only at the tip or only at the base, you might be looking at a localized abscess or a Felon. But sheath tenderness tracks the entire anatomy.
And finally, sign number 4, excruciating pain on passive extension. Not active extension where the patient moves it, but passive extension where the examiner pulls the finger straight. This is widely considered the most sensitive and specific sign. Why?
Going back to our physics principle, the resting flexed posture maximizes the volume of the tube. When you, the examiner, grab that patient's finger and passively extend it, you are violently stretching that tendon, pulling it taut, and dramatically shrinking the volume of the sheath.
Oh, wow. So you're actually increasing the pressure.
Massively.
Yeah.
You are applying Boyle's law to a closed space. You decrease the volume so the pressure spikes. You are essentially crushing an already highly pressurized tube of inflamed, infected tissue to its absolute physiological limit.
That sounds horrific.
That is why the pain is out of proportion. The patient will literally jump off the examination bed.
So once we've identified it using Kanavel signs, what is the treatment ladder? How do we decompress this tube?
It depends heavily on when you catch it. For very early cases, say within 12 to 24 hours of the puncture, where you have some swelling and tenderness, but perhaps no established tense pus collection yet, you can trial non-operative management.
Just admit them.
You admit them, start high-dose FAVI antibiotics, elevate the hand strictly, splint it, and observe them incredibly closely, reassessing every few hours.
But what if they fail that? Or more likely, what if they present with all 4 signs, blazing and established pus?
For established pus, which is the standard exam scenario, by the way, you must proceed to surgical drainage. The gold standard technique here is limited incision surgical drainage with a fenestrated catheter for continuous irrigation.
Walk me through that surgically. What does that actually look like in theater?
You make 2 small incisions. One distally in the finger, usually a mid-lateral incision to open the far end of the sheath, and one proximally in the palm, usually over the A1 pulley, to open the near end of the sheath.
Okay, 2 access points.
Then you take a fine pediatric feeding tube or a specialized fenestrated catheter, slide it into the proximal incision in the palm, and you physically flush liters of sterile saline through the sheath.
You're just hosing it out.
You are power washing the pus out from proximal to distal until the fluid runs completely clear. You might leave the catheter in place for 24 to 48 hours of continuous drip irrigation on the ward.
And what about the worst case scenario? Late, advanced, or necrotic disease where the tendon is already starting to die?
If the infection is neglected or the tissue looks dusky, a limited washout isn't enough. You have to do a full open irrigation and debridement. You make a massive Brunner zigzag incision down the entire length of the finger, fillet back the skin flaps, and completely open the sheath to mechanically debride dead tissue.
So it's a salvage operation at that point.
Completely a salvage operation.
Completely a salvage operation. Okay, let's drill this treatment ladder. I'm going to state it twice for the listener to send it. Treatment ladder for pyogenic flexor tenosynovitis. Early equals IV antibiotics, elevation, splinting, and close observation. Established pus equals limited incision surgical drainage, proximal to distal, with fenestrated catheter irrigation. Late or necrotic equals wide open irrigation and debridement.
Excellent.
Saying it one more time to lock it in. Early, 4 antibiotics, stripped elevation, splinting. Established pus, limited incision surgical drainage, flushing proximal to distal with a catheter. Late necrotic, full open irrigation and debridement.
The exam wants to see that you recognize established pus requires that limited incision catheter washout to decompress the sheath and save the tendon.
Which brings us to the summary line for Section 2. If you only remember one thing about this topic, Kanavel's 4 signs: flex resting posture, fusiform swelling, sheath tenderness, excruciating pain on passive extension, a pyogenic flexor tenosynovitis, usually caused by Staph aureus. Treat established disease with limited incision surgical drainage and proximal to distal sheath irrigation.
Absolutely pristine.
So we've established that an infection trapped inside a single tendon sheath in one finger is a surgical emergency. But biology is rarely completely self-contained.
True.
The hand is an evolutionary masterpiece, but it has some critical design flaws. What happens when the pressure inside one of these sheaths gets so high that the infection forces its way out or follows the anatomical pathways deeper into the arm?
That's where things get really bad.
That moves us from the isolated finger up into the complex anatomy of the wrist and forearm. Let's dive into the bursae, Parona space, and the horseshoe abscess.
This is a beautiful, intricate piece of anatomy, and it is an absolute favorite for the examiners because it tests your ability to trace a pathological process along a path of least resistance.
Okay, let's trace it.
Let's look at the flexor tendon sheaths of the hand again. For the index, middle, and ring fingers, digits 2, 3, and 4, the synovial sheaths typically start at the fingertip and end right at the level of the metacarpal heads in the palm. They are closed dead ends.
Just cul-de-sacs.
Right. But the flexor sheaths of the thumb and the little finger digits 1 and 5 are anatomically different.
Why are they different? Is there an evolutionary reason?
It likely relates to the mechanical demands of our grip. The thumb and the little finger are the anchors of our power grip and our pincer grasp.
Oh, that makes sense.
Yeah, their tendons require massive excursion and lubrication over a much longer distance to function correctly. Because of this, the synovial sheaths for the thumb and the little finger do not end in the palm. They are continuous.
They just keep going.
They run all the way from the tips of the digits through the tightly packed carpal tunnel in the wrist and extend proximally into the distal forearm.
So while the middle fingers are isolated cul-de-sacs, the thumb and the little finger have express routes straight out of the hand and into the arm.
Exactly. We give these continuous proximal extensions specific names. The sheath of the thumb continues directly into what we call the radial bursa. The sheath of the little finger continues directly into the ulnar bursa.
I like to picture this whole setup like a secret underground subway system. You have these 2 distant stations, the thumb station on the far left and the little finger station on the far right.
I like that.
If you just look at the surface of the hand, you would assume they're completely disconnected. But underneath the skin, they have these deep express tunnels, the radial and ulnar bursae running down into the wrist.
And the most critical part of this anatomy is that these 2 tunnels eventually meet.
Wait, they connect?
They converge at a central hidden transfer hub deep in the forearm.
And that hidden transfer hub is the legendary Parona space.
You got it.
Let's define the exact anatomical borders of Parona's space. This is a classic fellowship anatomy question, guaranteed point scoring material.
Parona space is a potential space located in the deep volar compartment of the distal forearm. Its purpose is to accommodate the massive sliding excursion of the flexor tendons.
Okay, so what are the boundaries?
Anatomically, it is defined by very specific boundaries. Anteriorly, or superficially, it is bordered by the conjoined sheaths of the flexor digitorum profundus, the FDP tendons.
Okay, FDP in front.
Posteriorly, or deep, it is bordered by the fascia covering the pronator quadratus muscle. Laterally, you have the flexor pollicis longus, and medially, the flexor carpi ulnaris.
That's a lot of landmarks.
It is, but the critical testable relationship is the anterior-posterior one. It is the space deep to the flexor tendons and superficial to the pronator quadratus.
Okay, repeating the specific boundaries of Parona's space for the listener,
Wow.
It is a potential space in the distal forearm connecting the radial and ulnar bursae. It lies deep to the flexor tendons and superficial to the pronator quadratus.
Exactly.
Specifically, between the pronator quadratus fascia and the conjoined FDP tendon sheaths. Let me state that a second time to lock the anatomy in. Parona's space connects the radial and ulnar bursae in the distal forearm. It lies deep to the flexor tendons, superficial to the pronator quadratus. It sits exactly between the pronator quadratus fascia and the conjoined FDP tendon sheaths.
Now, if we connect this anatomical map to the clinical pathology, the consequence of this subway system is the horseshoe abscess.
Oh, because of the shape.
Exactly. Because Parona's space connects the radial and ulnar bursae, an infection that starts with a simple prick to the thumb can travel proximally up the radial bursa, cross over through the transfer hub of Parona space in the distal forearm, and then travel distally all the way down the ulnar bursa into the little finger.
Wow, so that just loops all the way around.
It creates a massive, continuous U-shaped tract of pus spanning across the entire hand and wrist.
Hence the name, horseshoe abscess. It literally outlines a horseshoe shape from digit 1 down to the wrist, across, and up to digit 5.
So what is the clinical exam clue? How does the examiner paint this picture in a question stem? The stem will describe a patient who presents with a story of a localized injury to the thumb, maybe a rose thorn puncture. They develop Kanavel signs in the thumb, but suddenly, over the next 24 to 48 hours, the patient deteriorates.
Okay.
They unexpectedly develop Kanavel signs in their little finger, which had no trauma whatsoever.
Oh.
And simultaneously, they develop severe swelling, tenderness, and fullness in the distal volar forearm.
That's the triad.
The candidate must instantly recognize that specific triad: infection in the thumb, plus new infection in the little finger, plus distal forearm swelling. That equation equals a horseshoe abscess spreading through Parona's space.
It is an elegant anatomical trap, but an absolutely devastating clinical reality for the patient. I mean, you have to open the thumb, the little finger, and the forearm to wash it all out.
It's a massive surgery, yeah.
Let's wrap up this anatomical concept. If you only remember one thing about the deep spaces, the thumb and little finger sheaths connect via the radial and ulnar bursae through Parona's space in the distal forearm, creating the pathway for a horseshoe abscess.
We have now covered localized infections with the fight bite and the Felon. We've covered isolated tubular infections with Kanavel's Flexor sheath. We've covered deep-spreading anatomical infections with the horseshoe abscess.
That was left.
Now, we must escalate to the ultimate soft tissue killer, the apex predator of orthopedic infections.
We are talking about necrotizing soft tissue infection, often referred to as necrotizing fasciitis. This is where the clock isn't just ticking. It has practically run out. The tissue isn't just inflamed. It is actively dying before your eyes.
It's terrifying to see in person.
I can only imagine. What is the pathophysiology here, and what are the clinical signs we're looking for?
The pathophysiology is a runaway train. Bacteria, often polymicrobial, including strep, staph, and anaerobes, or sometimes a monomicrobial group A strep, invade the deep fascial layers.
Okay.
They release massive amounts of exotoxins. These toxins don't just kill tissue, they trigger an overwhelming immune response that causes widespread thrombosis clotting of the microvascular blood vessels supplying the skin and fascia.
So they basically choke off the blood supply.
Exactly. Because the blood supply is choked off, the tissue becomes ischemic and necrotic. It literally rots.
So you are looking for a terrifying combination of systemic immune collapse and local tissue devastation. Let's break down the signs.
Systemically, the patient is entering profound septic shock. The toxins are in their bloodstream. You will see hypotension, crashing, dangerously low blood pressure.
Right.
You will see marked tachycardia, a racing heart rate trying to compensate. You will see hypoxia, and altered mental status or confusion as the brain loses perfusion. The body is shutting down.
And what about locally?
Locally, on the hand or the arm, the hallmark sign early on is pain that is completely out of all proportion to the physical exam findings.
Stop there for a second, because pain out of proportion is a phrase thrown around a lot in medicine. What does it actually mean in this context?
It means you look at the arm, and maybe you just see some mild redness or a little swelling that looks like a standard cellulitis. But the patient is screaming in agony if you even brush the skin, or even if you don't touch them at all.
Oh, wow. So the surface doesn't match the reality.
Exactly. The ischemia of the deep fascia and the dying nerves are causing excruciating pain that the surface appearance cannot explain.
That's a huge red flag.
As the disease rapidly progresses over hours, the skin over the dead fascia will change. You will see rapidly spreading erythema. But the absolute hallmark, the ominous late-stage sign that guarantees the tissue beneath is dead, is the development of black bulo. These dark, blood-filled, gangrenous blisters and dusky gray necrotic skin that has lost all capillary refill.
I am going to state those hallmark signs twice, because recognizing them is literally a matter of life and death. Necrotizing soft tissue infection presents with systemic collapse, hypotension, tachycardia, hypoxia, confusion, combined with local devastation. Pain completely out of proportion, spreading erythema, black bulo, and dusky necrotic skin.
Yes.
Once more for the listener. Systemic collapse, hypotension, tachycardia, hypoxia, confusion, plus local devastation. Pain out of proportion, spreading erythema, the classic black bullae, and dusky necrotic skin.
Now, we have to consider who is most at risk for this. While it can strike a perfectly healthy young person from a minor scratch, the exam risk factors heavily feature immunocompromised and microvascular disease.
Like who specifically?
The classic exam patient profile is a rheumatoid arthritis patient who is on immunosuppressive DMARDs disease-modifying anti-rheumatic drugs, or a patient with long-standing poorly controlled diabetes.
Ah, okay.
Their immune systems are sluggish, and their baseline microvasculature is already compromised, creating a perfect storm for the bacteria.
In the modern hospital setting, we rarely rely on clinical exam alone if we have time. Are there diagnostics we should be ordering? The sources mention a specific scoring system.
Yes, the Ellerneck score, the laboratory risk indicator for necrotizing fasciitis. It is a vital tool when the clinical picture is still slightly murky in the early stages.
What goes into that score?
The Ellerneck score uses standard, easily obtainable laboratory values to stratify the risk. It looks at CRPC reactive protein, which will be massively elevated, total white cell count, hemoglobin, which often drops as red cells are destroyed.
Wait, hemoglobin drops?
Yeah, because the toxins destroy red blood cells. It also looks at sodium, which typically drops, creatinine, which rises as the kidneys take a hit from the shock, and glucose, which is often wildly deranged, especially in diabetics.
And what's the magic number?
A score of 6 or higher gives you a strong positive predictive value that you are dealing with a necrotizing infection.
Okay, let's talk treatment. I'm going to drop the host persona for a second and just be the junior orthopedic registrar on call.
All right, set the scene.
It is 3 o'clock in the morning. I've got a diabetic patient. Their L-Rhinic score is maybe a 5 borderline. Their blood pressure is a little soft, maybe 100/60, but they are holding steady after some IV fluids. The hand is swollen, it hurts a lot, there's some redness, maybe one tiny dark blister forming on the thumb. But I am exhausted. The theater staff is busy with an appendectomy.
I see where this is going.
Can I just admit them to the ward, start them on massive, broad-spectrum IZ antibiotics like tazocin and clindamycin, and just observe them closely with hourly neurovascular checks until the consultant ward round at 8 a.m.?
No. Absolutely not. This is a hill you must be willing to die on in your exam and in your career. You cannot delay.
So no observation.
The treatment for a suspected necrotizing soft tissue infection is emergent, radical surgical debridement of all necrotic tissue in the operating theater, alongside broad-spectrum IV antibiotics. Delaying surgery directly linearly increases mortality.
So it's spreading while you wait.
The infection tracks along the fascial planes at a rate of centimeters per hour. Every hour you wait on the ward, more fascia dies, more muscle dies, the systemic toxic load increases, and the risk of death climbs dramatically. You wake the consultant, you bump the appendectomy if you have to, you do not admit and observe.
But let me push back with one more clinical dilemma. Look at that thumb in my scenario. It is completely pale, dusky, and dead. It has no capillary refill. Could this just be an isolated vascular event? A clot in the radial artery? Should we call the vascular surgeons to do an emergency revascularization bypass to save the thumb?
No. A dead thumb in this specific clinical picture, with the systemic shock, the out-of-proportion pain, the elevated inflammatory markers, is due to infectious microvascular thrombosis.
So the tiny vessels are clotted off?
Exactly. The tiny vessels have clotted off because of the bacterial toxins and the massive inflammatory cascade. The tissue is dead because of necrotizing fasciitis, not because a major named artery like the radial or ulnar was severed.
So bypass wouldn't work anyway.
A vascular bypass will not save it. You cannot bypass 1 million thrombosed capillaries. The NICE is the only cure. You have to aggressively cut away the dead skin, the dead fat, and the dead fascia until you reach healthy, red, bleeding margins. And yes, that very often includes immediate amputation of the affected digit or even the limb to save the patient's life.
The reality of the disease is brutal. I am going to state that absolute surgical mandate twice. Treatment for necrotizing soft tissue infection is emergent radical surgical debridement of all necrotic tissue, including amputation if needed, plus alveolar antibiotics.
Yeah.
Never delay the surgery.
Never delay.
Saying it again to cement it. Emergent radical surgical debridement of all necrotic tissue, up to and including amputation plus IV antibiotics. Never delay the surgery for observation.
The examiners want to see that you recognize the ultimate emergency. They want to know you won't hesitate when the black bullae appear.
And that profound reality brings us to the summary line for this topic. If you only remember one thing, necrotizing infection is systemic collapse plus black bullae and pain out of proportion. Treat with emergent radical debridement and IV antibiotics. Never delay the surgery.
And breathe. That marks the completion of the infection half of our deep dive.
Okay, let's pause the forward momentum just for a moment. If you are driving, keep your eyes on the road, but engage your active recall. We are going to consolidate the first half of this deep dive with our first million-episode recap. I'm going to fire through the highlights like a peer-to-peer study session.
Let's hear it.
The infected hand, bite bugs. Staph aureus is the overall most common. Human mouth gives you Eikenella corrodens. Cats and dogs give you Pasteurella. The fight bite. The sliding trapdoor over the MCP joint. The treatment is always theater for a thorough washout, and you strictly leave the wound open to drain.
Correct.
The Felon, a compartment syndrome of the septated fingertip pulp. Treat with surgical division of the septa, but do not confuse it with a viral herpetic whitlow.
Never incise the whitlow.
Pyogenic Flexor Tenosynovitis. Remember Kanavel's 4 signs. Flexed resting posture, fusiform swelling, sheath tenderness, and excruciating pain on passive extension. Treat established pus with limited incision catheter irrigation.
Spot on.
The anatomy of spread. The thumb and little finger sheaths are continuous. They connect via the radial and ulnar bursae. They meet deep in the distal forearm in Parona space, creating the massive horseshoe abscess.
The subway system.
And finally, necrotizing fasciitis. Systemic septic shock plus local black bullae and pain entirely out of proportion. The absolute mandate is emergent radical surgical debridement. Never, ever delay.
A flawless high-yield summary. You have the infection module locked down.
So what does this all mean for our second family of emergencies? We leave the infected hand behind and we turn to the ischemic hand, the hand that is starved of oxygen.
The clock is ticking here too.
Exactly, where the clock is ticking, not because bacteria are multiplying, but because the blood supply has been choked off. This brings us to Buergers disease.
Buergers disease, formerly known in the textbooks as thromboangiitis obliterans. This is a fascinating, uniquely targeted, and devastating pathology.
How is it defined?
It is defined as an inflammatory, non-atherosclerotic, occlusive disease of the small and medium arteries and veins, predominantly affecting the distal extremities, the hands and the feet.
Let me stop you at non-atherosclerotic.
Yeah.
Because when we think of blocked arteries, we immediately think of cholesterol. We think of a 70-year-old patient who has eaten a high-fat diet for decades, building up calcified plaques in their vessels until they clog. But this is different.
Entirely different. There is no cholesterol plaque here. This is an inflammatory thrombosis. The endothelial lining of the blood vessel becomes acutely inflamed, highly cellular clots form within the lumen, and microabscesses can even develop within the thrombus itself.
Oh, wow. So it's a completely different mechanism.
The vessel simply aggressively clots off from inflammation, completely occluding the blood flow. Because the mechanism is so specific, there is a classic patient profile that you will see in almost every single exam question on this topic. It is practically pathognomonic for the disease.
And what's that profile?
The classic patient is a young male who smokes heavily.
Young, male, smoker.
Yeah.
That is a very specific demographic for severe vascular disease.
Yes. Usually between 20 and 45 years old. They will present initially with claudication, cramping, pain in their hands, arches of their feet, or calves during exercise caused by inadequate blood flow.
So it hurts when they use it.
Right. As it progresses, they develop severe rest pain and digital ischemia. Their fingertips or toes will be pale, cold, and exquisitely painful. Eventually, the oxygen deprivation leads to non-healing ulcerations and outright dry gangrene of the digits.
That's awful. Did they get any other symptoms?
They also frequently present with secondary Raynaud's phenomenon, cold-induced vasospasms, which we'll discuss in depth in a moment.
But the real clincher, the radiological image they will either show you on a screen or describe vividly in the text stem, is the angiography finding, the classic corkscrew collateral vessels.
Exactly. When you do an angiogram injecting contrast dye into the arteries to map the plumbing, you will see that the main straight arteries of the forearm or lower leg are abruptly occluded. They just stop.
Like a dead end.
But around those blockages, nature tries to find a way. You'll see these tiny, twisted, erratic, spiraling blood vessels trying to bridge the gap. These are the corkscrew collaterals.
I picture this as the body frantically building a network of chaotic, twisting side streets, because the main multi-lane highway has been permanently barricaded by inflammatory clots. It's building these twisted little detours to try and keep the fingertips alive, giving them that distinct spiral corkscrew appearance on the scan.
That's a perfect way to visualize it.
Let's state the classic triad for the exam twice, because if you see these three things, the diagnosis is made. Classic triad for Buergers disease: young male smoker, digital gangrene, corkscrew collaterals.
Memorize those three.
Saying it again for the flashcard memory.
Yeah.
Young male smoker, digital gangrene, corkscrew collaterals.
Now, because this is an inflammatory process directly triggered by a specific substance, the treatment relies entirely on addressing that specific trigger. The pathology is fundamentally linked to tobacco glycoproteins and the immune system hyperreaction to them.
So the treatment is?
Therefore, the single most important treatment, the absolute cornerstone of managing Buerger's disease, is smoking cessation.
And we don't just mean cut back to half a pack a day or switch to a nicotine patch. We mean total, absolute cessation.
It has to be absolute. The progression of the disease tracks tobacco use perfectly. If the patient continues to smoke even 1 or 2 cigarettes a day, they will continue to lose tissue. They will lose a finger, then another finger, then a toe, no matter what else you do.
The exams will offer you surgical options, right? Like sympathectomy, or medical options like calcium channel blockers, vasodilators, or aspirin to try and improve blood flow.
They will, yes. You can use those as adjuncts along with cold avoidance, but medical or surgical interventions are virtually meaningless in arresting the disease if the patient continues to smoke.
So amputation is just the last resort.
Amputation is strictly reserved for established, dead, gangrenous tissue that cannot be salvaged. But the primary, disease-modifying treatment is stopping smoking.
Let's repeat that vital point twice. The examiner wants to know you understand the pathophysiology. The primary disease-modifying treatment for Buerger's disease is complete smoking cessation.
The only thing that works.
Again, the primary treatment for Buerger's disease is total smoking cessation.
It is the only intervention proven to halt the progression and prevent further amputations.
Which gives us our definitive wrap-up for this vascular topic. If you only remember one thing about Buerger's, thromboangiitis obliterans presents as a young male smoker with digital gangrene and corkscrew collaterals, and the absolute key treatment is smoking cessation.
Excellent. Now, Buerger's is a physical, structural, inflammatory blockage of the pipes. The clot is a physical barrier. But what happens when the pipes are structurally normal, but they simply spasm close temporarily due to a hyperactive nervous system?
That brings us to Raynaud's phenomenon and its specific treatment ladder. We mentioned Raynaud's can happen secondary to severe issues like Buerger's or autoimmune diseases like scleroderma, but let's define primary Raynaud's phenomenon.
Primary Raynaud's phenomenon is an episodic reversible vasospasm of the small arteries and arterioles in the hands and feet.
Okay, a vasospasm.
Right. The blood vessels have smooth muscle in their walls, controlled by alpha-2 adrenergic receptors from the sympathetic nervous system. In Raynaud's, these receptors are hypersensitive. When triggered, the smooth muscle violently contracts, clamping the vessel completely shut.
And what triggers it?
This is typically provoked by 2 main environmental triggers: sudden cold exposure or acute emotional stress.
And it creates a very specific visual triphasic color change in the fingers.
Yeah.
White, blue, red. I want to break down exactly why those 3 colors happen in that order.
The triphasic change maps the physiological phases of the spasm. Phase 1, white or pallid. The trigger occurs, the artery violently spasms shut, and arterial blood flow to the finger instantly stops. The finger is drained of blood, causing severe ischemic pallor. It goes dead white.
White because there's no blood.
Exactly. Phase 2, blue or cyanotic. The small amount of venous blood trapped in the capillaries of the finger stagnates. The starving tissues extract every last molecule of oxygen from that trapped blood. Deoxygenated hemoglobin is dark blue-purple, so the finger turns cyanotic.
Wow, okay. And the last phase.
Phase 3, red or hyperemic. The spasm eventually breaks and the smooth muscle relaxes. The vessel dilates widely and a massive rush of fresh, highly oxygenated arterial blood floods back into the starving finger. This reactive hyperemia makes the finger turn bright, burning red.
White, blue, red. Ischemia, deoxygenation, hyperemia. Let me state that color sequence twice for the recall banks. Triphasic color change in Raynaud's. White, blue, red.
Perfect.
Again, white, blue, red. Now, while it might just seem like an uncomfortable parlor trick in mild cases, severe refractory Raynaud's can actually cause permanent fingertip ulceration and tissue loss from the repeated chronic oxygen deprivation. We need a way to stop the spasms. Let's walk through the 4 steps of the treatment ladder.
The treatment ladder is progressive, moving from lifestyle to medical to surgical. Step 1 is always conservative management. Cold avoidance. Wear thick insulated gloves, avoid sudden temperature drops, use chemical hand warmers, remove the trigger.
Okay, makes sense. And step 2.
Step 2 is the first-line medical therapy. Calcium channel blockers. The classic oral medication used here is nifedipine. Calcium is required for smooth muscle contraction. By blocking the calcium channels, you chemically relax the smooth muscle in the blood vessel walls, raising the threshold required for them to spasm.
Okay, conservative than oral calcium channel blockers. But here's where the pharmacology gets really interesting. Step 3 on the ladder, for severe refractory cases where the fingertips are starting to ulcerate.
Step 3 is the injection of botulinum toxin A, commonly known as Botox. The surgeon injects the Botox locally into the hand, specifically targeting the areas around the digital neurovascular bundles, the pathways where the nerves and arteries travel together into the fingers. This is a powerful tool to improve perfusion, heal ulcers, and drastically reduce pain.
Botox in the hand. And step 4.
And finally, if Botox fails and the tissue is threatening to become gangrenous, step 4 is surgery, a digital sympathectomy. The surgeon uses an operating microscope to carefully dissect out the blood vessels and physically strip away the tiny web-like sympathetic nerves wrapping around the arteries, permanently destroying their ability to receive the signal to constrict.
Let's repeat that 4-step treatment ladder twice. Raynaud's treatment ladder. 1. Cold avoidance. 2. Calcium channel blockers like nifedipine. 3. Botulinum toxin A injections to the digital neurovascular bundles. 4. Surgical digital sympathectomy.
And once more.
Saying it a second time. 1. Cold avoidance. 2. Calcium channel blockers. 3. Botulinum toxin A to the neurovascular bundles. 4. Surgical digital sympathectomy.
I want to expand on the Botox because it is a fantastic high-yield exam concept. Most of the general public knows Botox as a cosmetic treatment. You inject it into the forehead to paralyze the facial muscles and smooth out wrinkles.
Right. But here, we are using a cosmetic wrinkle paralyzer to save dying fingertips. Why does it work?
Botulinum toxin blocks the release of acetylcholine from nerve endings, paralyzing muscle. By injecting it near the neurovascular bundle in the hand, the toxin diffuses and paralyzes the specific smooth muscle cells residing in the walls of those spastic blood vessels.
Oh, so it forces them open.
It forces them to relax, dilate, and stay open for months at a time, chemically preventing the ischemic vasospasm.
It is a brilliant, elegant application of neuropharmacology. But we need to highlight a specific exam trap here regarding alternative medications.
Yes, we do. The exam multiple choice questions will often offer you methotrexate as an option for treating Raynaud's. You must know that methotrexate is not used to treat isolated Raynaud's vasospasm.
Wait, really? Why not?
Methotrexate is a powerful systemic immunosuppressant. It is used if the Raynaud's is a secondary symptom of a severe underlying autoimmune connective tissue disease, like scleroderma or lupus. It treats the underlying systemic autoimmune process. But it does absolutely nothing to treat the acute mechanical vasospasm itself. If the question asked for the treatment of the vasospasm, the latter is cold avoidance, calcium channel blockers, Botox, sympathectomy.
Clear as day. Wrapping up this topic, if you only remember one thing, Raynaud's is a cold and stress-induced vasospasm presenting with a white-blue-red color change. Treat progressively with cold avoidance, calcium channel blockers, botulinum toxin A to the neurovascular bundles, and finally sympathectomy for advanced tissue-threatening disease.
Excellent. We've covered inflammatory clots and chemical spasms. Let's move on to the literal, physical, mechanical crushing of the blood vessels.
Which brings us to hypothenar hammer syndrome. Even just the name itself sounds violent and industrial.
It is an industrial, repetitive stress mechanism of injury. Hypothenar hammer syndrome is a very specific vascular insult. It is defined as structural damage to the ulnar artery, occurring precisely at the anatomical location where the artery exits Goyon's canal and crosses superficially over the hook of the hamate bone in the palm.
The cause is right there in the name. It's caused by using the hand as a hammer.
Correct. The classic exam patient profile is a heavy manual worker, a mechanic forcing tires onto rims, a carpenter pounding joints together, or a machinist. They use the fleshy heel of their hand, the hypothenar eminence, as a literal blunt force hammer to pound objects into place.
Ouch.
Alternatively, it can be caused by operating heavy, aggressively vibrating machinery like a jackhammer for 8 hours a day.
Okay, so what's the pathophysiology?
The pathophysiology here is straightforward but devastating. The ulnar artery is a soft, delicate tube. The hook of the hamate is a hard, rigid, bony prominence. Every time the worker slams the heel of their hand against a hard surface, they are physically crushing the ulnar artery against the bone.
Right.
This repeated trauma shears and damages the delicate intimal lining of the artery. The artery reacts to the structural damage in one of two ways. It either completely thromboses and clots off, or the weakened wall balloons out and forms a true aneurysm right there in the palm.
Let me offer an analogy to really visualize the mechanical disadvantage here. Imagine a soft rubber garden hose carrying water. Now imagine that hose is resting directly on top of a jagged, sharp rock. That hose is the ulnar artery, and the rock is the hook of the hamate bone.
That's exactly it.
If you take a steel hammer and repeatedly, violently pound on that hose exactly where it sits over the rock, you are guaranteed to destroy it. You will either rupture the inner lining of the hose, causing a massive internal blockage, or you will weaken the rubber until it balloons out into a blister. That is exactly the physics happening inside the palm.
And the downstream clinical effects are what the patient actually presents to the clinic with. The damaged ulnar artery, or the turbulent flow inside the aneurysm, will start generating tiny blood clots.
And where do those clots go?
These clots break off, they embolize, and are thrown distally into the specific fingers that the ulnar artery supplies. This shower of microemboli causes severe, sudden pain, extreme cold intolerance, and acute ischemia specifically localized to the ulnar digits, the ring finger and the little finger. You can often diagnose it clinically with an abnormal Allen test showing delayed ulnar refill.
Let's repeat the critical anatomy and the specific digits affected, stating it twice for the listener. Hypothenar hammer syndrome. Anatomy is damage to the ulnar artery at the hook of the hamate. Digits affected are the ulnar digits, the ring, and little fingers.
The ring and little fingers.
Saying it again. Anatomy is the ulnar artery crushed against the hook of the hamate. Digits affected by the emboli are the ring and little fingers.
Now, if we want to elevate this review to true fellowship-level synthesis, we have to connect this pathology to the broader anatomical map. This is where a truly great exam candidate separates themselves from the pack.
Okay, I'd say that.
This exact same anatomical vulnerability, the hook of the hamate, was tested in a completely different module regarding nerve compressions.
Ah, yes. Guyon's canal and the ulnar nerve.
Exactly. The ulnar nerve and the ulnar artery travel intimately together through Guyon's canal at the wrist. Guyon's canal is classically divided into 3 zones. In zone 3, which is the most distal part of the canal right around the hook of the hamate, the ulnar nerve divides, giving off a pure sensory branch to the fingers.
Okay, I follow.
The exams love to ask, what is the most common cause of a pure sensory ulnar nerve lesion in zone 3 of Guyon's canal? The answer is ulnar artery thrombosis, or aneurysm.
Because the swelling clotted artery, or the ballooning aneurysm, is physically expanding and pressing right on that adjacent sensory branch of the nerve. It's a mass effect.
Exactly. So a vascular question about hypothenar hammer syndrome and a nerve question about a zone 3 Guyon's canal pure sensory lesion are functionally testing the exact same conceptual real estate. They are both testing your understanding of the vulnerability of the neurovascular bundle at the hook of the hamate.
That is a phenomenal cross-module connection to make. It turns 2 separate flashcards into one cohesive anatomical concept. Let's lock it in with our summary line. If you only remember one thing, hypothenar hammer syndrome is an ulnar artery injury at the hook of hamate, caused by repetitive blunt palm trauma, resulting in emboli and ischemia of the ulnar digits.
Which brings us to our final major topic for the vascular hand. We have looked at all the ways blood supply is lost naturally or traumatically through inflammatory clots and Buergers, chemical spasms and Raynaud, and physical crushing and hypothenar hammer.
But what about the reconstructive side? What happens when a surgeon spends 12 hours under a microscope trying to artificially restore blood supply to a severed finger, but the replantation is failing?
This is where we bring in some unconventional help.
We are talking about leech therapy and its associated exam trap, Aeromonas hydrophila. Applying leeches feels like we are stepping back into a medieval apothecary, balancing the bodily humors. But the medicinal leech, Hirudo medicinalis, is actually a highly regulated, FDA-approved medical device in modern microsurgery.
It is an indispensable tool. Medicinal leeches have a very specific, singular role in reconstructive surgery. They are used exclusively when a replanted finger or a newly transferred soft tissue-free flap is suffering from venous congestion.
Let's clearly define venous congestion because it is the opposite of ischemia. Ischemia means no blood is getting in. Venous congestion means blood is getting in, but it can't get out.
Exactly. In a microsurgical replant, you sew the tiny arteries back together to bring fresh oxygenated blood into the finger. Then you sew the tiny, thin-walled veins back together to drain the deoxygenated blood out. But veins are notoriously fragile. They often clot or kink or fail.
So what happens?
When the venous outflow fails, the strong arteries keep pumping blood into the finger, but it has nowhere to go. The tissue becomes massively engorged with stagnant, deoxygenated blood. Clinically, the finger swells up tight like a grape, and it turns a dark, dusky, purplish blue color. If you prick it with a needle, it bleeds incredibly fast, but the blood is dark purple.
That sounds like it's going to burst.
If you don't relieve that hydrostatic pressure, the swelling will eventually choke off the incoming arterial supply, and the tissue will die of congestion.
So to save the finger, you need a temporary vein. You apply a leech. What exactly is the leech doing biologically?
The leech does two critical things. First, the mechanical act. It bites the tissue and physically drinks a few milliliters of the congested blood, providing immediate, localized volume relief.
Okay, but it can't drink that much, right?
No. The second part is far more important. The leech is a biological pharmacy. As it feeds, it secretes a cocktail of chemicals into the bite wound. The most important of these is a protein called hirudin.
Hirudin?
Yes, hirudin is a highly potent, naturally occurring direct thrombin inhibitor. It is a powerful anticoagulant. It completely stops the blood from clotting at the bite site.
Wow, so it keeps the wound open.
Because of the hirudin, even after the leech is full and falls off 30 minutes later, that tiny bite wound will continue to slowly ooze and drain congested blood for the next 10 to 12 hours. The leech bite acts as an artificial, slow-drip external vein. This keeps the blood flowing through the tissue, keeping the flap alive for the 3 to 5 days it takes for the body to naturally heal and grow its own new venous drainage network.
It is an absolute marvel of utilizing nature in the ICU. The leech is the hero of the microsurgery unit. But wait, the outline specifically mentions a massive exam trap regarding a bacteria called Aeromonas hydrophila.
This is a classic trick.
Let me make sure I have this straight, because I've seen exam stems that make this incredibly confusing. If I have a patient with a blue, congested finger, and the lab calls to tell me the wound is infected with Aeromonas hydrophila, do I prescribe a leech to clear up that infection?
No. I am so glad you played out that confused logic, because that exact inversion is how the exam writes the distractors to trick you. You do not use a leech to treat an Aeromonas infection.
Then what is the exact relationship between the leech and the bacteria?
Aeromonas hydrophila is a gram-negative bacterium that naturally lives as a symbiotic commensal organism inside the digestive tract of the leech. The leech needs the bacteria to help it digest the massive blood meal it consumes. Therefore, when you apply a leech to a vulnerable, compromised surgical wound on a patient, you are purposefully introducing that gut bacteria directly into the patient's bloodstream.
So the leech causes it.
Leech therapy causes the Aeromonas hydrophila infection. It is the vector. It does not treat it.
Oh, so the infection is an inevitable iatrogenic side effect of the life-saving treatment.
Precisely. Leeches are prescribed strictly to treat mechanical venous congestion. Aeromonas hydrophila is the dangerous, tissue-destroying complication of using the leech. And because we know this complication is almost guaranteed to happen due to the biology of the animal, we must proactively protect the patient.
How do we protect them? What is the pharmacological defense?
The absolute standard of care is prophylactic antibiotics. The moment a patient is prescribed leech therapy, before the leech even touches their skin, you must start them on an IV antibiotic that specifically covers Aeromonas.
Which one?
The standard testable choice is a fluoroquinolone, like ciprofloxacin, or alternatively a third-generation cephalosporin. You give the antibiotic to protect the patient from the side effects of the leech.
Let me state those 3 critically linked facts twice to ensure the listener doesn't fall into the exam trap. The active anticoagulant chemical secreted by the leech is hirudin. The bacterial pathogen carried in the leech's gut is Aeromonas hydrophila. The required prophylactic antibiotic class is a fluoroquinolone.
Hit it one more time.
Saying it again, linking them together. The active chemical is hirudin. The bug introduced is Aeromonas hydrophila. The required antibiotic to cover it is a fluoroquinolone like ciprofloxacin.
Remember the sequence. Venous congestion requires leeches. Leeches carry the bug. Fluoroquinolone antibiotics kill the bug.
That perfectly cleanly untangles the trap. Closing out our final section with our summary line, if you only remember one thing about microsurgical salvage, leeches relieve venous congestion via the anticoagulant hirudin, And Eromonas hydrophila is a dangerous complication of leech therapy covered prophylactically with a fluoroquinolone. It is not an infection treated by leeches.
We have successfully survived both the infectious and the vascular emergencies of the hand.
Which means it is time for our second mid-episode recap, covering the ischemic half of our deep dive. I'll hit the core highlights quickly to consolidate the knowledge.
Do it.
Buergers disease, thromboangiitis obliterans. The classic presentation is a young male smoker with digital gangrene. The angiogram shows corkscrew collaterals. The absolute non-negotiable treatment is smoking cessation.
Right.
Raynaud's phenomena. Vasospasm triggered by cold or stress. Look for the triphasic color change. White for ischemia, blue for deoxygenation, red for hyperphochemia. The treatment ladder climbs from cold avoidance to calcium channel blockers to Botox injections at the neurovascular bundles, and finally, sympathectomy.
Perfect.
Hypothenar hammer syndrome. Repetitive, blunt trauma to the palm physically crushes the ulnar artery where it crosses the rigid hook of the hamate, causing emboli and ischemia, specifically in the ring and little fingers. It shares its anatomy with zone 3 Guyon's canal lesions.
The exact same spot.
Leech therapy, used exclusively for venous congestion in flaps and replants. It secretes the potent anticoagulant hirudin. However, it carries the gut bacteria Eromonas hydrophila, which must always be prophylactically treated with a fluoroquinolone.
A flawless, comprehensive recap.
And now, as promised to the listener doing the dishes or driving home in the dark, we move directly into the finale, the lightning round. I'm going to fire rapid one-sentence questions at you. We are going to drill these absolute core facts one final time. Distracted listener, this is where you actively test your recall. Try to shout out the answer in your car before the expert says it. Ready?
Ready? Let's do it.
What is the specific bug associated with cat bites?
Pastorella multicida.
Name the 4 signs of pyogenic flexor tenosynovitis.
Kanavel's 4. Flexed resting posture, fusiform swelling, tenderness along the sheath, and excruciating pain on passive extension.
What is the anatomical space involved in a horseshoe abscess?
Parona space, deep in the distal forearm.
What are the ominous late-stage signs of necrotizing fasciitis?
Black bullae, dusky skin, and pain entirely out of proportion to exam.
You see a young male smoker with corkscrew vessels on an angiogram. Diagnosis.
Buergers disease, or thromboangiitis obliterans.
What is the injection used for refractory severe Raynaud's?
Botulinum toxin A, injected near the digital neurovascular bundles.
What is the infectious complication of medicinal leech therapy?
Eromonas hydrophila, requiring fluoroquinolone prophylaxis.
And that brings us to the finish line. Just look at the sheer breadth and depth of the survival guide we've built over the last hour.
We really covered a lot.
We did. We started at the microscopic level with bite bugs and the devastating enclosed space pressures of Kanavel's sheath and the apical Felon. We mapped the hidden subway lines of the horseshoe abscess through Parona's space. We confronted the terrifying systemic shock and black bullae of necrotizing fasciitis. We navigated the vascular blockages of Buergers, the chemical spasms of Raynaud's, the crushed plumbing of hypothenar hammer, and ended with the biological marvel and double-edged sword of medicinal leeches.
We covered a tremendous amount of high-yield ground, but before we sign off, I want to leave the listener with a broader concept to ponder, tying it all together.
Oh, please do.
Think about what all of these seemingly disparate emergencies have in common. The human hand is an absolute evolutionary marvel. It is a masterpiece of dense, highly specialized microanatomy designed for precision, power, and sensation. But it is exactly this tight, interconnected engineering, the unyielding fibrous septa of the fingertip, the shared synovial tendon sheaths that run continuously for inches, the rigid bony hooks underlying delicate superficial arteries that makes the hand so uniquely, terrifyingly vulnerable.
The very design that gives us our incredible dexterity also creates the perfect environment for catastrophic chain reactions.
Exactly. An infection in the hand doesn't just sit in the tissue, it pressurizes a closed tube, causing a vascular necrosis. A crushed artery doesn't just bruise, it throws a shower of emboli down a terminal pipe. When you look at a patient's hand in the emergency department, don't just see the surface skin. See the interconnected subway lines, the pressurized synovial tubes, and the vulnerable neurovascular pipes. When you truly understand the engineering of the masterpiece, you instantly understand the mechanism of the emergency.
That is a brilliant unifying way to look at it. A final reminder to respect the anatomy, look small, and act fast. Listener, you have officially survived this deep dive into the infection and vascular modules. I highly encourage you to put this audio on replay during your next commute. Let the lists, the pathophysiology, and the repetition wash over you until Kanavel's signs and the Buergers triad are permanently cemented in your brain, ready for exam day.
Best of luck with your revision, and trust your training.
Keep looking small, keep acting fast, and we will see you on the next deep dive.